want to mention, if you want any of the slides that I'm going to show you, you can just Google my name or search my name and Medicine Manitoba and go to my website, download whatever you want. I did want to get some idea of the audience. Can I ask how many people here are from Cuba or Latin America? Just put up your hand if you're from Cuba or Latin America. We have a pretty decent number. And how many physicians here? And how many of you are intensive care specialists? Some. And how many of you are from ER? Okay, so mostly ER, but some ICU guys, and then nurses. How many of you are nurses or non-physicians? Few, not too many. So mostly docs. Well, that's cool. So as the title says, antimicrobials in septic shock, nothing else matters. Now I don't mean that literally, but what I do mean to say is that there were, I did want to mention, everybody always asks me, where is Winnipeg? Right? So Winnipeg is in Canada, and it's in the center of Canada, and it is the coldest state or provincial capital in the world, bar none. It's colder than Vladivostok, Siberia. It's colder than Anchorage, Alaska. This is actually a picture of my home just last week. So that's why I'm particularly happy to be. No, it's not from last week. It's actually from last winter. This isn't a, let's see, this isn't a hill. This is actually a really big pile of snow. We get so much snow there that rather than just plowing it to the side of the street, we actually have to plow it, and then we have to carry it away because it never melts. So we make these piles of snow throughout the city. So that's Winnipeg. And I'm really enjoying Cuba, so you can imagine why. So we're going to talk about septic shock today. How much of a problem is it? Well, obviously it's a pretty big problem. Untreated septic shock is almost always fatal within 24 to 36 hours. It's a big deal. I won't get into the epidemiology of it. We've only got half an hour, but actually I'm just going to turn on my timer so I know when I'm talking too long. But it is a very big deal. Now, I want to point out that since around 2000, there have been at least 4 major studies that have suggested new therapies for sepsis. These were supposed to be the big things in the early 2000s. 3 of them were in the New England Journal, 1 in JAMA. These approaches were broadly adopted. We're going to see what happens. Glycemic control, physiologic corticosteroid therapy, activated protein C, protococcussion alpha activated, and of course the well-known goal-directed resuscitation. Unfortunately, all of them have fallen by the wayside. This is the initial intensive insulin therapy in critically ill patients, looking at cumulative survival. This is by Grief Vandenberg, and this changed practice. People started doing very tight insulin control between about 2.5 and 4 micromoles per liter, and it was adopted in the United States and Canada, probably 90%. Based on 1 New England Journal study, 1 single center study. Unfortunately, this is what happened. Additional studies were done, and when you do a meta-analysis, what you find is overall, there is no effect whatsoever. And in fact, this therapy has been abandoned to a great extent, except maybe in cardiovascular ICUs, there was some evidence that it was useful there. But by and large, I would suspect that none of you are doing this anymore. All right, what about stress dose steroids? Dr. Anand's classic study, this was in Critical Care Medicine as an abstract in 2001, but eventually published in JAMA, and what they found was that people who were responders to steroids, corticosteroids, and those who were non-responders, both seemed, in terms of ACTH stimulation, both actually seemed to get a benefit with treatment with low-dose steroids. And this was, again, came out in JAMA, very influential paper. Everybody adopted the therapy. I can assume all of you can remember not too long ago giving 100 milligrams of hydrocortisone every 8 hours. But this is what happened. The Corticus study was done. They randomized about 500 patients. I believe the study was terminated early for futility. Basically, in this international trial, they found no difference between those who got low-dose steroids and the placebo group. The therapy was substantially discredited. So that's gone now. What else? What about recombinant human activated protein C for severe sepsis? There was the famous study in 2001 published by Bernard, where he demonstrated that giving patients activated protein C actually gave approximately a 6% survival advantage over not giving it in patients with severe sepsis, that is sepsis with organ failure. Again, this was a big deal. Eli Lilly, who owned the product, put out a big educational campaign. They put hundreds of millions of dollars into advertising and education. And at least in Canada, more in the United States, it was adopted reasonably well. It went on a lot of the professional guidelines, surviving sepsis and such. Mind you, it was $10,000 a course, and got you about a 6% survival advantage. So in Canada, we weren't using it too much. And my guess is in other places that are a little bit more cost sensitive, like Cuba, my guess is you weren't using it that much, but maybe some. Unfortunately for them, what they found is they did a repeat study. This time it was a shock study called Prowess Shock, and they enrolled, as you can see, about 1,700 patients. And overall, again, they found no difference in mortality whatsoever. Between this and a few other studies, the product was withdrawn from the market. It's no longer commercially available. So again, here's a study, here's a product that was thought to be very useful, very big deal 10 years ago, completely gone. Now, I will tell you that at least in my group, we don't think it's completely gone, at least the idea. This is a study of intravenous heparin in septic shock. It's a propensity match study out of a database that we have. We have a database of about 12,000 cases of septic shock. We found a lot of patients around 1999 were getting troponin levels in their blood because troponin had just been introduced. We find a lot of patients with elevated troponin who we thought were septic shock. But then the ER docs thought, well, they got troponin, they got septic shock, maybe they're having an MI too. So they got introduced to intravenous heparin. And one of the really interesting things we found was that those that got intravenous heparin, usually for about 2 days on average, actually had about 6 or 7% survival advantage. So we're now doing an RCT to look at this worldwide, and I wanted to bring this up in part because if anybody has an interest in such an RCT, we're actually putting in a Wellcome Foundation grant, and we're looking for under-resourced countries to participate. So we already have funding for it to a great extent. So last one, this is the goal-directed resuscitation. This is probably the biggest thing that's come down in critical care sepsis work probably in the last 25 years. This was the classic study by Rivers and colleagues. It was, again, single-center study. Always got to watch out about single-center studies. Published in the New England Journal in 2001. Now, what they found was, essentially what they did in this study, let me tell you about it to refresh your memory. They had one group of patients who got standard care in essentially a relatively low-quality hospital in the United States, what we call a county facility. It's a public facility. They tend to get the bottom end of resources, basically. And then they had another arm that was supposed to be treated the same. Both groups got central catheters, but this group got a special central catheter that could measure central venous oxygen saturation. And essentially, the goal of this was they were going to try to hit CVP targets in both arms, but in the experimental arm, they were also going to try to hit a central venous saturation target, essentially. And they would start by giving fluids to achieve that target. If that failed, they would give blood. They also gave digoxin and dobutamine. They don't mention the digoxin much anymore, but it was in the protocol. So what they found was, now obviously you couldn't blind this completely, but they did the best they could. What they basically found was that within the first 6 hours, the experimental arm got about 1.5 liters more fluid. They got more red blood cells. Pressors were about the same, and they got more dobutamine. Now, the really interesting thing was it had a tremendous apparent impact on outcome. A 42% decrease in relative risk of in-hospital and 28-day mortality, 33% relative risk reduction in 60 days. You needed to treat 6 to 8 people to save 1 life. It was incredible in terms of that difference. And this really affected care. I would proposition that virtually every advanced ICU ER in the world adopted this. What happened? This was 2001. Well, there are some people here from Pittsburgh, the Prisma Lab, and they know about what happened because they coordinated one of the studies. There was probably on the order of $100 million to $150 million spent to do just 3 studies. And these are the 3 studies. There was the ARISE study that was out of Australia, and of course lots of people from there here. EGT, early goal-directed therapy, usual care, no difference in outcome whatsoever. Again, can't blind this, but this is as good a study as you can do. And there was the process study, again, EGT and septic shock. This was the one I think that was out of Pittsburgh, wasn't it? Yeah. And they actually did 3 groups here. They did a protocol-based EGT, they did a protocol-based standard therapy, and then they did usual care. Protocol-based standard therapy is what we would call EGT light. They didn't use the central venous catheter, but they tried to do the same thing. And again, what you see here overall, in terms of hospital mortality and mortality in 1 year, is no impact on survival whatsoever, despite the fact that virtually every ER in the world was starting to do this. And then finally, there was a PROMISE study that was run out of England, another large study, over 1,000 people. By the way, the previous study was also over 1,000 people. So the PROMISE study, again, EGT versus usual care, no difference whatsoever in terms of outcome. So the thing is, what's left? What's left? And what's left is something that we've had for over 60 years, and that's antimicrobials. In fact, this guy, Paul Ehrlich, was a famous physician of the early 20th century, and he actually defined the major points in terms of using antimicrobial as well. We've been looking for a magic bullet for 80 years. We've had the magic bullet the whole time. The problem is, we've been throwing the bullet at the patient instead of putting it into a gun and using it most effectively. He said, basically, in terms of optimizing use of antimicrobials for serious infections, rapid work, rapid hit hard and hit fast. Now, I don't have time to talk about all aspects of this, but I'm going to talk to you about the key aspects. I want to ask you something. What do you think the mortality of septic shock is in your institution, combining both ER and ward patients? And I can tell you, ER patients account for about 40% in most hospitals, ward patients for about 60%, right? So what do you think the mortality is in total in your hospital if you have solid septic shock? I want you to put up your hand. How many of you think it's probably over 70%? Anybody? 1, okay. How many think it's, say, 50 to 70%? Few, okay. How many of you think it's 35 to 50%? That's the majority, okay. And how many of you think it's 20 to 35%? Some people think it's that good. Okay, I will tell you that depending on where you live these days, if you're in an area, I want to ask, how many of you actually measure your time to antimicrobial routinely? Decent number of you do. That's excellent. Again, what's the time you think? You think that your time from hypotension to antimicrobial therapy, who thinks it's under 2 hours? You got a few. Now, we're talking about the whole hospital now, not just the ER. Whole hospital. Okay. So nobody. Who thinks it's 2 to 4 hours? Decent number of people. 4 to 6. Decent number. Who thinks it's more than 6 hours? If you think it's more than 6 hours, I can almost guarantee you that your mortality is about 60%. If you're 4 to 6 hours, your mortality is probably between 40 and 50%. I'll show you a formula that helps you define this soon. Okay, there are 2 aspects to giving early antimicrobial therapy, or at least giving appropriate, giving antimicrobial therapy that's appropriate early. So we said one aspect is you want to give antibiotics to which the organism is sensitive. How often do we fail to do that? There's a lot of studies that have been done. That number varies between 20 and 40%. Okay? About 20% in the ER, sometimes 10 if you're really good, but generally 10 to 20% in the ER, but as high as 40% up on the ward because you tend to have more resistant organisms. And remember, giving the wrong antibiotic is the same as giving no antibiotic at all. Now, people have shown that if you give the wrong antibiotic for something like sepsis without shock, in fact, Marin Coliff has shown this. If you give the wrong antimicrobial in somebody who has sepsis without shock, mortality goes up by about 50%. That's a big increase, okay? What happens in septic shock, though? This is data from a study that we did. We looked at about 6,000 septic shock cases. And we simply asked the question, what's the survival, what's the appropriateness rate? This is in turquoise, so what's the appropriateness rate? I call this the hit rate, how often we hit the organism. And what's the survival in yellow, depending on different conditions. Now, our overall hit rate is about 80%, and our overall survival was about 45% when we did this study. This was about 2009, you can see. Culture positive and culture negative were relatively similar. Bacteria positive, bacteria negative were similar. Community infections had a higher hit rate and a higher survival than nosocomial. Look at these other infections. This is different types of anatomic infections. Pneumonia, intra-abdominal infections, skin and soft tissue, UTIs, catheter-related infections, laboratory-confirmed bloodstream infections. You look at these, you can see that the hit rate increases and decreases, and the survival tracks very well with it. Now, if you look at the survival, depending on whether this is now in turquoise, survival, hospital survival, and this is death, depending on whether, so this is survival if you got appropriate therapy, this is survival if you got inappropriate therapy. So they're both survival, but this is appropriate therapy, this is inappropriate therapy. 55% survival if you got appropriate therapy at the first opportunity, 11% survival if you got the wrong antibiotic. And that's assuming that you make the change 24 hours later or whenever when you get a culture back. Just getting it wrong in the first opportunity gives you a five-fold, 500% difference in survival. Culture positive, culture negative, very similar. For culture negative, this is empirically appropriate as opposed to microbiologically appropriate for culture positive. Bacteria positive, bacteria negative, all very similar. And look at these different infections. This one in particular, this is laboratory confirmed bloodstream infections without an obvious clinical source. A lot of these are patients with Staph aureus where you can't find a clinical source, or Candida where you can't find a clinical source. 48% survival if you get it right at the first opportunity. 3% survival if you get it wrong. 3%. 18-fold difference in survival. If you get the antimicrobial wrong in somebody with septic shock, they're going to die. Now, when I started this project, this series of projects that I've been working on in septic shock, I went to my colleagues in the hospital and I said, I went to the nurses, I went to the doctors, I went to everybody. And I said, after you have hypotension documented, and by the way, finding when hypotension occurred in the hospital or in the ER is very easy, because by and large, when a nurse sees a patient who looks sick, the first thing they do is they take vital signs, and if they're hypotensive and they look sick, there's two things they do next. One is they call the doctor, and two is they document it, right? So finding out when they went hypotensive is easy, and JACO, at least in the United States and Canada, requires that for any intravenous drugs, you got to put a time down. So you can actually figure out the times quite easily from hypotension to the initial antibiotics. So when I ask people, how long do you think it takes? And this is around 2003, so about 10 years ago. I can tell you that uniformly, everybody told me, an hour and a half. And I think some of you are still saying that. But when I actually measured it in my place, I was actually completely astounded, really astounded, and with how long it was. And so I thought to myself, you know what? Maybe we're just stupid here. Let me go across the river to the other side. The other side of the river, by the way, in Winnipeg is the Francophone side, the French-speaking side. The French, as everybody knows, are brilliant. And so I thought I would go and ask them. And they said, of course, Dr. Kumar, you Anglophones, you don't know anything. We do this right. So they measured their times, and actually they were the same as us. So then I called my friends in Toronto. Now, Toronto is probably a little bit like Havana, but Toronto is basically the center of Canada. The people in Toronto are absolutely brilliant. And if you don't believe me, you can just ask them. They will tell you they're brilliant. So they said to me, Dr. Kumar, I trained in Toronto. They said, you know, you've been away too long. You've adopted the insight of your Western colleagues. We do it much better. So they were kind enough to measure it for me. The same thing, time to antimicrobial therapy. They were an hour longer than us. So then I went to my friends in the States where I did 10 years of training. And they said, Dr. Kumar, at the American medical system, we do everything better. And so they said, of course, we'll measure it. And they measured, they were the same as Toronto. So I never meant to create a study that was 2,500 patients, but I couldn't believe the results. And that's why I kept getting bigger. What we found was that only about 5% of patients got appropriate antimicrobial therapy within 30 minutes of documentation of hypertension. But if they did, their survival was about 87%. Right? About the same as severe sepsis without drugs. Now, if you look at the next half an hour, we got up to about 15% cumulatively. The survival in that group was about 84%. Thereafter, for every hour delay in getting antimicrobials on board, the average survival dropped by about 7.5%. Our overall survival was 45% because our median time to get drugs on board was 6 hours. And I can assure you, every institution I've talked to since then, every doctor I've spoken to, who says to me, no, we're not that long. We don't measure it, by the way, but we're not that long. Every one of them, when they actually measure it, is somewhere between 5 and 7 hours. If you don't measure it, you can almost guarantee that you're up in that range and that your mortality is going to be quite high. In fact, if you don't get your antimicrobials by about 12 hours or so, your chance of survival drops to under about 15%. Now, where does this statistically break? If you get your antimicrobial in the second hour compared to the first, so there should be a line here that seems to be missing. So if you get your antimicrobial in the second hour compared to the first, your chance of dying is already statistically increased, and the odds ratio just skyrockets. This is a logarithmic scale, so you can see the odds ratio goes up to 100. Okay? In fact, we've rerun this study with larger numbers. We did this original study with about 2,500 patients. We've now done it with about 12,000 patients. We can show a break point at 20 to 30 minutes. In fact, there is no real break point. Basically, in the first couple of hours, for every 5-minute delay, your chance of dying goes up by about 1%. Right? It's an incredible impact. Now, remember we talked about activated protein C gave you a 6% improvement in survival? Right? 6% improvement in survival. It costs $10,000 US per course. And what I can tell you is if you put $10,000 into a simple QA program in your hospital, you can drive the time to antimicrobial down by several hours, at least 2, and you will get an improvement in mortality of at least 15%. I can prove this to you. Now, by the way, does this apply to all subgroups? Yeah, it applies to every subgroup you want to look at. Documented suspected, bacteria negative, gram-positive, gram-negative, even fungal infections. All statistically show a very tight relationship to simply how fast you get your antimicrobial. You want actually a rough estimate of survival for your entire hospital. Figure out what your mean delay is. Right? Figure out, take 50 cases, figure out your delay, and just plug it into this equation. 0.79 is the survival of the first hour if you exclude no one at all. In that first slide, I excluded people who were getting CPR in the field or who were absolutely moribund. But if you exclude nobody at all, survival of the first hour is 0.79 divided by 1.12, which is the adjusted odds ratio of death per hour delay to the X power, where X is the hours of delay. That should be an exponential, so it should be up here. That'll give you a pretty good estimate of survival. Recently, people have shown that this same time-dependent effect applies to sepsis without shock. I have to tell you, I'm skeptical of this because of this reason. If only 10% of patients with severe sepsis had septic shock, their impact could drive this whole relationship, basically. And in fact, in this study, 80% of the patients who had severe sepsis actually had septic shock. So I'm not convinced this applies to severe sepsis without shock. In fact, I think they're two different diseases. And as far as my institution goes, we accelerate antimicrobial therapy for septic shock, but we actually take time to figure things out with sepsis. All right. So you guys know about the bundles for sepsis. This is the Surviving Sepsis 12-hour bundle. Lactate level, this is sort of the 3-hour bundle. This is from 2012. Get lactate level, get blood cultures prior to administration of antimicrobials. Administer broad spectrum antimicrobials within 1 hour for septic shock and 3 hours for severe sepsis. And then, of course, fluid resuscitation. Now, bundles have consistently been shown to improve outcome. The application of a bundle strategy along with screening at your place will improve outcomes substantially. In fact, there are studies that show you can halve your mortality, half it. By the way, can somebody tell me what the population for Cuba is? How many million? 11 million? Okay. Sorry, pretty close? Okay. It's relevant for something I'm going to show you later. Now, when you do these kinds of bundles, there are some limited studies where they actually try to break out the aspect of the bundle that has the big impact. You can do that. And what you find, for example, in this study, is that in fact it was time to antimicrobial that had the big impact, right? They also saw some effect with activated protein C, and there are reasons for that because I think activated protein C and heparin, for example, will work in more critically ill patients, but not less ill patients. But certainly antimicrobial time had a big impact on outcome. This is some of our data. By the way, I want to be very careful. I don't, especially with ER guys here, I'm not literally trying to say that nothing but antibiotics matters, okay? Other things do matter. Good basic care matters. But, to give you an example, this is our data set. We broke it into quartiles in terms of number of patients. Again, 12,000 patients or so. We saw no impact on outcome whatsoever related to pressor delays. Zero. Couldn't find a single. When we looked at fluid resuscitation, the only aspect of fluid resuscitation that came into a significant result in multivariate analysis is actually the amount of fluid that you gave in the first hour, not the first 6 hours, but the first hour. And what we basically found there was that if you gave less than about 0.75 liters, you had a lower survival rate. If it was a lot less, it was significantly lower. This is actually significant at about 0.05, 0.04. It's kind of marginally significant, but it's significant. So certainly the amount of fluid that you give has some relationship. But the fact is, these days, almost everybody gets a liter of fluid in the first hour. So it may just be that there isn't much room to improve there. Whereas when you looked at antimicrobial in terms of different quartiles of getting your drug on board, so 0 to 2, 2.3 to 5.8, 5.9 to 14.3, greater than 14 hours, you can see a very tight relationship with outcome. This is significant at a p-value with about 15 zeros out. Okay? This is incredibly significant. Now, getting at the bundle issue, as I said, almost every bundle study has tended to show that you can improve outcomes by applying the sepsis bundle. Chuck Nathanson and Barokia did a really nice study a few years ago where they asked, okay, if sepsis bundles work, what aspect of the sepsis bundle are we actually actively changing? And what they found was when you looked at the bundle, the one thing that changed consistently in this meta-analysis is time to antimicrobials. Essentially, the heterogeneity here is 0. The p-value is significant overall, which suggests this is a real effect. You look at all the other things like crystalloid usage, vasopressor usage, inotropes, RBCs. Either they are not significant, or alternately, the heterogeneity is quite high. So basically, the major thing that changes, by and large, is how fast you give antimicrobials in these bundles. And yeah, bundles work. So, if you look at if antimicrobial delay is that important, what if you look at different hospitals and figure out the relationship in terms of outcome? If in fact it's an important parameter of outcome, then hospitals that have shorter delays should have better outcomes. This is the 30 hospitals in our database. Community hospitals in red, academic hospitals in blue, and as you can see, here's the delay, here's the survival. You put a nice line right through that. In fact, it's interesting because the community hospitals tend to be faster and have better survival. 2 reasons. One is they tend to have less complicated cases with less resistance, but also they don't have layers and layers of interns and residents to go through before you get anything done. Okay, the next 2 are going to be 2 of the most important slides I'm going to show you. Okay, these are the take-home lessons. Simply put, what are the causes for delays? Okay, now, the failure to recognize that hypotension represents septic shock is a big one. A lot of times people will see a patient, they'll be hypotensive, they may have evidence of infection, but people don't put 2 and 2 together and say, this is septic shock. Number 2 is the effect of inappropriate antibiotic conditioning. When you give the wrong antimicrobial, vancomycin for E. coli septic shock, it's the same as giving no antimicrobial at all. And that's a big problem because it drives huge delays. Usually you won't get it correct until 36, 48, 72 hours later. And the cause of that is failure to appreciate the risk of resistant organisms in certain scenarios. So for example, we all know that if you're immunosuppressed, you need broad spectrum therapy because you're at risk of resistant organisms. But a lot of people, particularly people in the ER and the residents on the ward, forget that if you are immunocompromised in the broader sense, chronic liver failure, chronic renal failure, dialysis dependence, diabetes, end-stage lung disease, all these things make you immunocompromised, and you also require broad spectrum therapy, but we forget. The other thing that we forget is the impact of antecedent antimicrobial use. If you've been on several weeks of this or that, you're almost certainly going to be resistant to it. So those are the big ones. And quite frankly, I could have guessed those. As an academic physician, it was in my head. I knew these things were big issues. The ones that drove me absolutely insane when I figured them out were the small logistic things that I'd never considered. So for example, when I gave this presentation to my ER nurses, they said to me, Dr. Kumar, we'd be giving the antibiotics a lot faster, but you doctors are always coming around and saying, draw blood cultures and then give antibiotics. And the problem at our place, can I have a couple more minutes? Or no? Yeah. The problem at our place is that our ID techs are very busy. You call them, and it's half an hour, 45 minutes, an hour before they get there. They said, if you wouldn't write that, we'd be giving the antibiotics a lot faster. I didn't know that. Transfer, that adds, so you've got a new team to assess the patient. That adds 2 hours. You've just increased the mortality by 15%. Failure to use stat orders. I think the nurses in the ER are the best nurses in the city, ER and ICU, okay? They're absolutely excellent. But even there, you're going to have some rookies. Now, when I make orders for ER patients, I assume everything's stat. I mean, the patient's in septic shock. Of course it's stat, right? I mean, I don't want you to do it tomorrow. So I assume everything is stat. But when you actually check, what you'll find is that if you don't write some kind of thing like stat or immediately or something like that, about 5% of the time they just do it at the routine time. So if you write an order for a drug, let's say Cipro. Cipro is given twice a day, right? So if your patient, any pharmacists here at all? Pharmacist? We got one pharmacist. Okay, if I write an order for a drug like Cipro in the hospital, right? And I don't put stat on it, what time is it going to be given? It's going to be given at the standard times, right? It might be 10 a.m. and 10 p.m. If the patient comes into the ICU at 11 a.m., they're going to wait until 11 or 10 p.m. until they get it. 11 hours delay, you've just increased the mortality by, well, you probably actually killed the patient. Okay? Now you think this doesn't happen, but the fact of the matter is, I told this to a friend of mine, Peter Brindley in Edmonton, and he said, and he's one of those guys who lives in the ICU, and he said, no way, this doesn't happen in my ICU. I'm here all the time, I would know if this happened in my ICU. So I said, Peter, I'll give you $500. Hire a student, measure your numbers, and if I'm right, you buy me dinner in the best place in town. And Sure enough, he bought me dinner in the best place in town. And then he published his observation and said 5% of the time they weren't getting their antibiotics. And he didn't put me on the paper. What about failure to recognize the presence of inappropriate antimicrobials equals no antimicrobials at all when you're responding to clinical failure? How often is it you're round in the ICU in the morning and you say, nah, this patient's not doing very well. I think we put him on 2 narrow drugs yesterday night. Okay, maybe it's 10:30 in the morning. And the nurse, we need to broaden it out. And the nurse says to you, you know, Dr. Kumar, we just gave the Cepha whatever or the Gorillacillin like 30 minutes ago. Should we wait until the next dosing interval to give the new drug? And because, you know, they're worried about seizures or something like that. But here's the thing. If you give the wrong antibiotic, it's the same as no antibiotic. Which means that if you actually got it wrong, it's not covering, by waiting until the next dosing interval, what did you do? You just killed the patient. And I've done this, and I bet you guys have done it too. And then finally, what about the order that you give antimicrobials? When you have septic shock, do you give 1 drug, 2 drugs, 3 drugs maybe, right? Of those, one of them is your go-to drug. It's the one that covers 90% of your pathogens. Usually it's a beta-lactam or cephalosporin, penicillin type drug, right? But that drug is also usually the one that's a bit more expensive. So which one does your hospital make it a bit harder for you to get to? That one, right? Now the other 2 drugs, say vancomycin and gentamicin, they're nice agents, but vancomycin basically covers maybe 5% of your pathogens uniquely, and gentamicin is a good supplemental agent, but it's lousy as a primary agent, right? So you write this order, you don't put a sequence on it. Which one does the nurse give first? The one she can get her hands on first, which is usually the cheapest drug, right? So she gives gentamicin, you give 1 drug at a time, then you give vancomycin. You've delayed things by 3 hours, increased the mortality projection by 20%, right? So what we've done is we've done a couple of things. And I'm going to go through this quickly because I know I'm actually out of time already. The first is that the presence of hypertension in a patient with known or suspected infection should be considered to be septic shock in absence of a definitive alternate explanation. What I mean to say is, look, if you come into the hospital, you're diabetic, you've got crushing retrosternal chest pain, but you've got a little bit of a pulmonary infiltrate. But on the other hand, you've got 4 millimeters ST elevation and troponin elevations. Yeah, I'm going to assume that you don't have pneumonia. You've probably got septic shock, that you don't have pneumonia, septic shock, that you have cardiogenic shock. If you're a known cirrhotic and you've got some white cells in the urine, but on the other hand, you've got 2 liters of blood on the floor that you just vomited, you probably have hypovolemic shock. But short of that, if you've got somebody with known or suspected infection, that should be considered to be septic shock in the absence of a definitive alternate explanation. We've mandated in our city that there are no transfer from the ER before antibiotics are given, even if you have to give it IM. All initial orders, any IV antibiotic in our city are now automatically stacked. Anywhere in the city, anywhere in the hospital, automatically stacked. We've developed syndrome-based algorithm-driven guidelines similar to meningitis and neutropenic sepsis, where we have basically an order set that says if you have the syndrome, right? You don't need to know if it's pneumonia or meningitis or this. If you have the septic shock syndrome, you get broad-spectrum antibiotics. Now, our order set says you have to give the antibiotic within 30 minutes of the order. Why? Because if you don't, nurses have to do an incident report. And nurses hate doing incident reports. So it actually focuses the mind really well. And the best thing we've done, we've taught all our junior physicians and even some of the nurses now that they can give our primary drug, the beta-lactam. How do they give it? Anesthesia people here? Anybody in anesthesia? How do you give beta-lactams in the OR? You give them push, right? We've just taught them, you know what? Just give it push. So we send them, we say, go and see the pharmacist. They'll give you the drug in a syringe. You walk to the patient bedside. You tell the nurse what you're doing. You push it in over 1.5 minutes. You're done. You've bypassed all the delays. So, last couple of slides. Can you actually do this? This is data, antimicrobial delay versus year for my city. Okay, these are the 6 hospitals. HSC and St. Pete are the big places. These are very small places, so there's a lot more variability. You can see at the beginning, say around 1996 to 98, we were up around 7.5 hours overall. By 1999, when we had data for other places, we were about 7 hours. We started thinking about this here. Time started coming down. We We put a program in place just to decrease times, and we got down to about a little under 3 hours. A little under 3 hours, we would expect an improvement in outcome of about 25% raw. What did we see? What we saw is exactly that. We went from 45% survival up to about 60% survival. We saw a 22% increase in survival. Easy to do. We did this without any money. It's just a simple, trivial thing. If you put $10,000 into it, you can do this too. So, finally, sepsis bundles improve survival in sepsis and septic shock. A critical component of the sepsis bundle that improves outcome appears to be accelerated antimicrobial therapy. Simply put, speed is life. Thank you.